So yeah, thanks to Randy for inviting me to give this short talk. I'm Jordan Harrod. I'm a rising third year in HST, and I work with Emery Brown and Ed Boyden on brain stimulation for anesthesia and machine learning for an assortment of ongoing projects in both labs, including an upcoming project that relates to this topic, which is pretty exciting. So today I'm going to be talking about something that I've recently become really interested in because of my work on minimally invasive brain simulation systems, which is how machine learning techniques and a bit more broadly optimization techniques can be used to focus spatial targeting of non-invasive brain stimulation modalities for the purposes of relieving symptoms of depression. So to give a quick overview of the points that I'm going to be hitting, starting with why I'm focusing on depression and how treatments are currently done, and then moving into where machine learning and optimization techniques might play a role. So in terms of why depression, I'm sure a lot of people here already know this, but depression is a commonly occurring mental disorder that has serious negative impacts on the lives of patients. It affects roughly 1 in 5 people worldwide and is one of the leading causes of disability because it disrupts pretty much every aspect of a person's life. Historically, depressive disorders have been treated with therapy, exercise, medication, in some severe cases, ECT. However, some people continue to experience symptoms of depression after going through multiple rounds of treatment, and this is called treatment-resistant depression. Which has prompted researchers and clinicians alike to explore other treatment options. So on the right, you can see a figure with the share of the population with depression globally from 2016. Those numbers have only gone up, especially in people of my age since then. So advances in neuroimaging technologies have played a significant role in helping us explore other treatment options. As they have helped us understand the network properties in the brain and how they map to behavior so that we can better target structures involved in relieving symptoms of depression. And this additional information can improve the efficacy of non-invasive stimulation modalities. I'm going to be focusing somewhat on transcranial magnetic stimulation for this talk, but this definitely applies to other modalities as well. Specifically in depression, work in the Human Connectome Project has shown that it's definitely possible to improve spatial targeting of TMS. However, while neuroimaging allows us to see these surface and deep structures relatively easily, the stimulation modalities themselves have limitations in terms of the structures that they can reach and with what level of specificity due to the underlying physics that govern these systems. So as an example for TMS, TMS of the prefrontal cortex has been shown in several studies to be an effective treatment for depression. In case anyone isn't aware, TMS generates a changing magnetic field that induces electric current in specific areas of the brain, depending on where you position the coils, which you can see in figure A. For patients who are undergoing TMS treatment for depression, neuronavigation based on MRI is commonly used to find the optimal positioning for these coils. And that positioning may be adjusted over the course of the TMS sessions based on symptom progression, as well as the strength of the magnetic field. Initially, patients typically receive daily treatment for a month to 6 weeks, and then the sessions taper off in frequency based on symptom progression. And so while TMS has been extremely useful, there is some heterogeneity in treatment response, which is typically attributed to a lack of a precise therapeutic target for individual patients. Additionally, accessing that target becomes a bit challenging because it depends on factors including conductivity differences between the CSF and gray matter, interpatient physiological differences. In particular, a paper from 2018 looked at the relationship between brain scalp distance and TMS stimulation intensity, as well as CSF thickness and intensity in 50 head models from healthy subjects in the Human Connectome Project. And quantified a significant negative correlation between brain scalp distance and maximum stimulation intensity, as well as in CSF thickness and stimulation intensity, and in particular the brain scalp distance explained about 70% of the variance that they found in the induced electric field. So more recent work has shown that machine learning based optimization techniques and just newer optimization techniques in general might help us find more precise and patient specific targets. And I've reiterated this, but since it came up during the keynote Q&A, I'm using a somewhat broad definition of machine learning here that focuses a bit more on the optimization methods than the models themselves. In fact, one of the initial challenges with using machine learning for patient-specific treatment optimization is that supervised learning techniques usually assume that you have most of your relevant data set already. And in our case, as we discussed in the previous slide, the patient feedback comes with each additional session. So you're getting new information every time, which is great, but you may not have enough information to train a supervised model until somewhat well into the treatment plan itself. You also run into issues of dimensionality in your data, which can prevent some traditional machine learning models from finding solutions quickly because of the number of parameters that you need to search through. Just happens to be prohibitively large. Recent advances in optimization and model-free learning, which I'll talk about in more detail in a second, can allow us to optimize a model in real time based on the patient feedback from each session, and more efficiently search through parameter spaces to figure out which set of stimulation conditions can improve treatment outcomes. And one thing that's kind of interesting to me is that pre-training these systems based on the knowledge that we already have, things like standard head models, human connectome data, patient-specific data, may also help us expedite this process even further. So as an example, I'll start with Bayesian optimization, which isn't actually a machine learning model, but is a technique that can be used to optimize models efficiently, including one type of model that we'll talk about next. It's a strategy that's used to optimize black box algorithms without initial knowledge of what our final function should look like. And so closed loop Bayesian optimization can allow us to use real-time patient feedback to improve our stimulation conditions. And so the figure on the right is actually from a 2019 paper that looked to efficiently determine the optimal tax parameters to maximize phosphine intensity. So patients would receive 2 blocks of tax where the original stimulation parameters, which in this case are frequency and phase, were randomly determined and then are updated based on the optimization. In total, there were over 190 possible configurations that patients could receive, and these configurations were optimized for in 5 minutes on average per patient. So Bayesian optimization traditionally starts with a random initialization, usually a Gaussian prior, but one of the interesting things that I mentioned in the last slide for this is that the content of the target and treatment optimization allows us to use existing data, things like head models, patient data, our understanding of network distributions to potentially craft priors that might actually expedite this optimization even further. And this is especially useful for something like a TMS depression treatment plan, because unlike this tax example, you're not just sitting doing the experiment over and over again until you can get it to converge in one day. You're doing it over a longer period of time. So having a prior for our models that more accurately represents the situation can be fine-tuned from that, might help us find that sweet spot a little bit earlier. And then the second approach that I'll talk about is reinforcement learning. So this one can be called machine learning. It's rooted in Markov decision processes and control theory. And the goal broadly of reinforcement learning is to determine which actions lead to the highest reward in a given state for every state that you encounter. And this can be a little bit vague because reinforcement learning algorithms are often model-free. Things like Q-learning are model-free. So we don't develop our model with the knowledge of the probability that you will move from any one state to any other state. Reinforcement learning has been used in the literature for adaptive treatment of epilepsy in order to derive effective stimulation protocols to reduce seizure frequency while minimizing the overall amount of stimulation. And there is a diagram, I think, on the top right for that, yes. And then has also been used for autonomous optimization of targeted stimulation to increase the number of spikes in spontaneous bursts, shown on the bottom right. There are a few examples of this that I found for depression specifically, mostly because, not necessarily mostly because, but my hypothesis, I guess, is because you do need to be able to quantify your reward system and the states that the patient would be transitioning in and out of within the context of the treatment. which could involve something like the incorporation of maybe a sensor or using patient feedback to determine what state that you're in. There are definitely more optimization algorithms than this and more approaches that can be used. So evolutionary algorithms is something that I've been seeing come up a lot more recently, which attempt to model the evolution of a population over time, but I focused on the ones that were particularly interesting to me and were also the ones that I saw being used for things like neuroadaptive treatments in academia, focused on hypothesis testing, but also in clinical settings focused on treatment optimizations. This is also an opportunity to potentially understand different patient subtypes by analyzing how stimulation paradigms converge between patients who are experiencing potentially either similar disorders with different symptoms or similar symptoms, but maybe the stimulation doesn't converge the same way. So that would also be an interesting opportunity to better understand how we can tailor treatments better to patients. And so with that, I can take questions.